हो गया?
Sir, we are live now. Good to go.
Good evening, everybody. I'm Michael D'Souza, the Vice President of Astera Division. Is very happy to be part of this webinar of epilepsy diagnosis of management from bench to bedside. I would like to call upon Dr. Soumya Darshan Nayak, who is currently the Assistant Professor of Neurology in SCB Medical College, Cuttack, Odisha. He has passed his DM from SMS Medical College from Jaipur and has worked as a senior registrar in the Department of Neurology, Chipmur, Pondicherry. Dr. Nayak is affiliated as a life member to IAN. He's also a member of MDSI, member headache of subsection of the IAN, life member of EPICON, as well as the member of epilepsy subsection of IAN. His area of interest is primarily in research of headache disorders, demyelinating disorders, as well as movement disorders. Dr. Nayak has a string of achievements and awards to his credit. He has been awarded in Economic Times as the most inspiring neurologist of India on 1st July 2019. He's also awarded the best case presentation National Headache Update in Kolkata in 2019. He has the fellowship in headache at Sydney, Australia in August 2018. Moreover, he's also having the APJ Abdul Kalam Award for work in the field of medicine in 2018. ISC Award for the work in the field of medicine in 2017, the second runner-up of North Zone TAISA in neurology 2012-13. Apart from that, he also has won the first prize in API Odisha chapter on free paper presentation in 2006, best poster presentation in Epicon Patna, and National Junior Boys Chess Championship when he was in his early youth. As you know, Dr. Soumya Darshan Nayak has a very illustrious career, and I wish him to take forward today's webinar as the chief chairperson and moderator of this event. Thank you very much, sir. Over to you, Dr. Nayak.
Thank you, Dr. Michael, for these wonderful words. Now we move on to epilepsy, our topic of discussion today. As all of you know, 2/3 of the epileptics live in third world countries, especially in India. And who better than our two guest speakers to deliver on how to approach to a case of epilepsy and how to manage such a case. And to start this discussion, we have with us for the first topic, that is the diagnosis of epilepsy, the pearls and pitfalls. We have none other than Dr. Santosh Kumar Das. He is a distinguished neurologist of Odisha, and he is currently working as assistant professor neurology at KIMS Hospital in Bhubaneswar. He has passed DM neurology from NIMHANS, Bangalore, and he has to his credit the President's Award for the best resident at NIMHANS. And he has lots of papers and publication to his name. And we will have him talk on the pits, on diagnosis of epilepsy, the pearls and pitfalls. After that, we will have Dr. Ujjwal Roy, who will be joining us. He's the consultant neurologist of Orchid Hospital at Ranchi, and he's not only a dear friend, but also an epileptologist and a movement disorder specialist. So we'll hear him next on the medical management of epilepsy. So first, we will start with Dr. Santosh speaking on the diagnosis of epilepsy. Over to you, Santosh.
Thank you, sir, for your nice words. Good afternoon, everybody. I am sharing my screen. Sir, is it visible, sir?
Not yet now, sir. Not yet.
Now?
Yes, sir. So you can go to the full screen mode now.
Visible
Yeah,
now?
perfect, sir. Perfect.
Okay. So, good afternoon, everybody. Now, today's topic is epilepsy diagnosis, falls and pitfalls. Actually, I prepared. This is a totally basic thing. I think everybody knows about many of the things. I just review the things. So, the outline of my talk is seizure and epilepsy. What is the new classification of epilepsy? What are the mimickers of epilepsy or differential diagnosis of seizures? How to approach a suspected case of seizures or epilepsy? What are common varieties of epilepsy we are seeing in our OPD, and how to investigate before managing the case of epilepsy? So, coming to the basic thing, what is the difference between a seizure and epilepsy, so that we can differentiate between what is a seizure and what is epilepsy. As you all know, seizure involves a sudden temporary burst of electrical activity in the brain that change or disrupt the way messages are sent between the brain cell or the neurons. So these electrical bursts can cause involuntary changes in the body movement or function, like sensation or behavioral changes or any change in awareness. That is the presentation of the seizures. So every brain has the potential to seize. But what happens in the epilepsy patient? They have usually lower seizure threshold, so they are more prone to recurrent episode of the seizure. So are all seizures are epilepsy? No. The answer is no. So it is important to know the difference between what is seizure and what is epilepsy. A seizure is an event and can be a symptom of other medical problems. So seizure is a event, and epilepsy patients are more prone for recurrent seizures. So all seizures are not epilepsy. We have to be very clear in differentiating between the seizure and epilepsy. So what is the epilepsy? A person with epilepsy is higher risk for recurrent seizure. So recurrent seizure means epilepsy. So a diagnosis of epileptic patient does not define the cause or the outlook. So epilepsy is a spectrum disorder. There are many different types of seizures in that epilepsy patient, and there are many different epilepsy syndromes. So the impact of epilepsy on a person will vary depending on what is the type of seizure, how frequent the seizures are coming, and how severe is the seizure, the areas of brain affected, so that the patient can present it with different type of seizures, what is the cause of the epilepsy, how the person is responding to the treatment depends on the cause of the epilepsy, and is there any underlying brain abnormality that is causing the seizure. These are the things we should keep in mind when we see a patient with epilepsy. So what is not an epilepsy? A patient with seizure, but he is not an epileptic patient, or he is it is not a epilepsy. A person can have seizure from many physical causes, like any acute medical illness or trauma that causes seizure. So these are known as provoked seizure or symptomatic seizure. So these are not epilepsy. This is a clear-cut distinction between a provoked seizure and a epilepsy. So this should not diagnose as epilepsy. Common causes everybody knows, like acute medical condition like infection, trauma, metabolic causes like hypoglycemia or hyponatremia, any head injury, any stroke, or any excessive toxins or withdrawal from alcohol. So all these can cause seizures. So they are not epilepsy patients. These are symptomatic seizures or provoked seizures. They need short course of treatment, not long duration of treatment as in epilepsy. We should be clear in, we should keep it clear in mind. So a patient of seizure, everybody knows that seizure, like in migraine, having three stages. One is prodrome. Sometimes it is associated with aura. Then the ictal stage, where he has tonic-clonic movement or any type of movement, or any post-ictal stage. So aura is the stage before the ictus or the actual episode of the seizure. So it occurs few seconds prior to the seizure, and in ictal stage the patient will seize. There may be tonic-clonic or tonic or sometimes non-convulsive episode. And post-ictal is the after the seizure, the recovery period. There may be sometimes transient experience of fatigue, drowsiness, headache. So most of the time the seizures go through these three stages. Sometimes aura may be absent, but ictal and post-ictal stage are most of the time it is there. So careful history is very important to identify the what happened during the ictus and what happened in the post-ictal period. So there are many events. These are close mimickers of seizures. So when we are seeing a patient with suspected case of epilepsy, we have to clearly differentiate between a non-epileptic event. These are mimickers of epilepsy, and the most commonly seen patients in OPD is the syncope. So we have to clearly differentiate between syncope and seizure. As I already told, seizure is due to a abnormal burst of electrical activity in the neurons, which does not happen in the syncope. Syncope is the loss of blood supply, transient blood supply to the brain that causes syncope. But it is the mechanism of seizure and syncope are completely different. There are clear distinction between two. So I will tell the next slide. So the mimickers most commonly is the syncope. Sometimes migraine can present with seizure-like episodes or movement disorders, or in nocturnal seizure we have to clearly differentiate between sleep disorders like REM behavioral disorder or NREM sleep disorders. We have to clearly differentiate before diagnosing them as a epilepsy. So we have to exclude all the mimickers of seizure before diagnosing as a epilepsy or a seizure. So there are many clear distinctive points between seizure and syncope, but I will emphasize on four points. First one is in most of the time in syncope, if you clearly take the history, there must be some trigger which is usually absent in the seizure unless there is a reflex epilepsy. So the common triggers in syncope, everybody knows, is some fear or some prolonged standing or pain or seeing some blood. Sometimes many patients will sudden brief loss of consciousness. So first is the trigger, then the duration of loss of consciousness is very important in seizure, usually few minutes, but sometimes syncope, it is less than the seizure, few seconds. And other associated symptoms, throbbing or tongue bite, urinary incontinence are happen mostly in seizure, but it can happen in syncope. And most important thing is the post-ictal state. We have to inquire what happened after the patient regained the consciousness. Is there any post-ictal confusion or headache, or he was immediately normal? So prodrome, trigger, duration, and post-ictal is the very important thing. These are clinical points. Apart from that, EEG you can do to rule out whether any epileptiform discharges are there, but to differentiate between seizure and syncope. So there are clear seizure, there are non-seizure episodes or mimickers, and most commonly we have to differentiate between a seizure and a pseudo-seizure, that is psychogenic non-epileptic seizure, that is PNES, psychogenic non-epileptic attack. So these are having a clear-cut psychological origin. So a person of psychogenic non-epileptic attack may not be aware of any psychological distressing factors. So many times young females will present a seizure-like episodes. So they may not aware, they will refuse, there is not associated any psychological or distressing factors. A person with psychogenic seizure is not consciously in control. So they are many times we thought that they are voluntarily doing, but sometimes they are not consciously in control their symptoms. And about 90% of cases having some psychiatric problems like depression, anxiety, or personality disorders. There is often associated history of any sexual assault, emotional or physical abuse in people with psychogenic seizures, and about half of the patients with psychogenic seizure having post-traumatic stress disorder. So during careful seizure history, we have to differentiate between seizure, a syncope, or a psychogenic non-epileptic seizure. So before labeling them that there is a seizure or epilepsy. So we can see the patient, we can take the history, we can ask for any social factors or any psychogenic factors or any history of post-traumatic stress disorder or any emotional abuse in the family that can give rise to psychogenic non-epileptic seizure. So there are very clear points how to differentiate. Usually, the main points between the true seizures and a pseudo seizures, there are few points I am emphasizing few. First thing, pseudo seizures often last longer. So a seizure usually, unless it is a status, it usually sees seizure subsides within 5 minutes, but pseudo seizure usually lasts longer, up to hours. And post-ictal confusion tends to be absent. Sometimes they become completely normal after the event, which usually not happened in generalized tonic-clonic seizure. So, and the during the ictus, usually in pseudo seizure, there are clear-cut features like forcefully eye closure, all pelvic thrusting, or hyperventilation. These are clear-cut points which we can inquiry in any patient to identify whether it is a true seizure or pseudo seizure. So there is prolonged duration, post-ictal confusion usually absent, and during the seizure, whether there is a pelvic thrusting or hyperventilation, or there is forcefully eye closure, which is usually not happened in seizure. We can ask, or we can
Sir, your voice has gone mute, sir. संतोष सर, आपका वॉइस म्यूट हो गया है.
So you are mute, sir.
So during
Sir, you are mute.
संतोष सर, आपका वॉइस म्यूट हो गया है सर. संतोष सर.
हाँ आ रहा है.
अभी आया सर.
So approach to case of seizure, whenever we are seeing a possible case of seizure in the emergency room.
Santosh, you can keep yourself close to the laptop.
Hello, sir, आ रहा है?
Yes. Now you are audible.
So when we are seeing a patient with seizure in our emergency room, there is clear-cut. We should have a clear-cut distinction in our mind whether it is a seizure or it is not a seizure. So diagnosis of epilepsy, when we are seeing a fast attack of seizure, it may be fast seizure or it may be a second seizure. If it is a fast seizure, we have to, that is new onset fast seizure, we have to be carefully evaluate the patient whether he is a prone for recurrent attack of seizure or he is very low risk of recurrent attack of seizure. So the risk for another seizure or risk of epilepsy in a new onset seizure, like if there is EEG abnormality in the EEG abnormality is there, or imaging abnormality is there, or it is a fast attack of nocturnal seizure, so that patients are risk of epilepsy. And if it is second seizure or recurrent seizure, so they are clear-cut epilepsy patient, we can start treatment directly. But in fast seizure, unless there are high risk criteria are there, you can wait before starting any treatment. There is the new onset seizure or epilepsy. If it is not seizure, other medical causes are there. As I already told, you have to rule out whether it is a syncope or it is a sleep disorder before starting or labeling them as a epilepsy. Or if it is not epilepsy, whether it is a provoked seizure like any infection, trauma, or toxin, likewise you can treat. You have to rule out whether it is a psychogenic, treat with psychotherapy. So there are 4 categories: whether it is a new onset seizure, whether there is a recurrent seizure requires treatment, whether that is a seizure mimicker like syncope, or it is a provocative seizure, or it is a psychogenic seizure. So there are 5 categories. We have to differentiate between all these 5 in any patient who presented with seizure, especially those patients who require multiple drugs. Many times there is pseudo seizure and patient are taking multiple drugs. We have to be very, very careful without increasing the dose again and again to rule out whether the patient is a case of psychogenic seizure. So history taking in a seizure is very, very important before labeling or before. So there are few points I will just tell. Before the spell, that is the oral symptom, whether any risk factor is like sleep deprivation or any stress, whether any sickness is there, whether he is taking over the alcohol or drugs, or in what stage the seizure happen and which happen, whether it is a nocturnal or whether it is a daytime seizure, what he was doing during that seizure. And during this spell, there are many signs are there. If any eyewitness is there, it is important. If there is no eyewitness there, it is difficult to get the history. But if eyewitness is there, you can ask many questions, whether eye is opened or not, whether head deviation is there or not, whether any automatism is there or not, whether any nystagmus in eye, whether eyeball movement is there or not. Many questions you will ask to characterize what happened during the ictal episode, and you also check what happened during the post-ictal. So history taking in seizure is very much important before labeling the seizure. What happened during the oral stage, what happened during the ictal stage, what happened during the post-ictal stage before labeling as a seizure or epilepsy. So there are many ictal symptoms are there. So patient can present with multiple symptoms. So we have to be very, very careful keeping all the symptoms in mind, because not all patients will present with a generalized tonic-clonic movement. There are other symptoms like ictal symptoms, like you can see there are motor symptoms. So there may be tonic-clonic movement. Sometimes there may be dystonic posturing. Sometimes there is Fencer posture like figure of 4. There may be sensory symptoms during seizure. So you should have asked what are the sensory symptoms, whether there is any auditory symptoms, whether there is any olfactory hallucination, or you can ask for any autonomic symptoms like there is a flushing is there, or there is any sweating or any palpitation, or you can ask for emotional, sometimes the patient having anger, sometimes crying, sometimes laughing like the elastic seizure. You must ask the automatism during the test, whether there is the chewing movement or any pedaling of movement or any pelvic thrusting, all these automatic movement, or sometimes there is psychic symptoms like deja vu and hallucination, illusion that can happen. So ictal symptom, you always ask for ictal symptom, not that all patient will present with a tonic-clonic movement. You have to ask whether non-motor symptoms like sensory symptom, emotional symptom, autonomic symptoms, and automatism in all epileptic patients to localize and lateralize from where the seizure is coming. So epileptic seizure, as I already told, aura, ictus and post-ictus, the aura may be visual hallucination, sometimes auditory, sometimes olfactory. So carefully history is important. Then the motor seizure, as I already told, whether there is tonic movement, tonic or tonic-clonic, myoclonic movement. Sometimes complex motor seizure like hypermotor, like pedaling movement. These are complex hypermotor seizures, or sometimes spatial seizures like drop attacks or atonic seizure. So if you ask careful history, then there are some points where you can localize from where the seizure is coming in during history taking. Like many symptoms, there are clearly demarcation between a dominant and non-dominant hemisphere. You can ask whether there is any dystonic hand posturing that is clearly localized to the contralateral origin of the seizure, or figure of 4, that is fencing posture, that is also contralateral. But if you can see the post-ictal nose rubbing and unilateral eye blinking, post-ictal aphasia, sometimes they are very ipsilateral, and aphasia, as you already know, dominant hemisphere. So the history is very, very important to localize and lateralize what happened during the ictus to characterize the seizure onset or the seizure origin. So coming to the next, I already told how to correctly differentiate between seizure and what is epilepsy, what are the mimickers, and what is psychogenic seizure. So next is the new classification of epilepsy. Before going deep into the epilepsy diagnosis, there are and National League Against Epilepsy in 2016 clearly laid out the classification. So the seizures are basically now divided into 3 categories, whether it is a focal onset or generalized onset, or onset is unknown. Like this, the epilepsy patient also, whether it is a focal or generalized, sometimes combined or unknown. And there are clearly demarcated epilepsy syndromes. So the seizure type or epilepsy type among the 4 types, and the causes of seizure are also very, very important, whether there is any structural damage, whether in a genetic or infection, metabolic, or it is a immune mediated seizure, because the treatment depends most of the time, what is the cause of the seizure? So the classification again clearly told if there is focal onset, whether that time the patient is aware or not aware, or there is a motor symptoms or non-motor symptoms. There is a generalized onset, whether it is a motor symptom. So these are the guidelines. Everybody knows. I just clearly told because there are three categories: whether it is a focal, generalized, or unknown. If it is focal, whether it is a motor and non-motor, or there is loss of awareness, or the patient is aware during the seizure. So if you see the then second part is the what causes the patient a seizure patient is an epilepsy patient. So there are many causes of epilepsy. If you see this slide, so there are hundreds of causes of epilepsy. Structural causes, or there is an infection, or if there is no cause, if there is genetic cause, or there is metabolic or immune mediated. So 5 categories of causes we have to be clearly investigated the cause before giving any treatment. So there is may be structural, there may be metabolic, there may be immune mediated, there may be infection or genetic. So genetic nowadays, many patients who are doing genetic test, if you are not able to find, especially in children, no cause is there, MRI is normal, EEG is showing recurrent, recurrent EEG is showing lot of epileptiform abnormalities and patient having resistance to medicine. So we have to find out the genetic cause. So 5 causes we have to keep in mind before evaluating all patients of epilepsy. So metabolic causes, I will just show one slide, and most important thing which presents with very refractory seizure is GLUT1 deficiency syndrome in children. I saw almost 5-6 patients. They are very refractory to treatment, and because by investigation by CSF glucose and blood glucose correlation by them. So this is very important to keep in mind. And second metabolic causes of epilepsy is pyridoxine dependent seizures. So they will respond very dramatically to IV pyridoxine or to oral pyridoxine. So these are we should keep in mind when evaluating a refractory seizure. And third thing is mitochondrial disorders which present with recurrent seizures, and because if we give the drugs which produce mitochondrial damage like valproic acid, they aggravate the seizure. So we have to be very careful in mind when we are evaluating a case of epilepsy. When we are unable to diagnose what causes the patient of epilepsy having recurrent seizure and not responding to treatment, we have to be very careful to keep in them. So next is the epilepsy syndromes, because as you know, there are a lot of epilepsy syndromes. MRI, many times it is normal, but EEG, there are characteristics abnormality in many patients required genetic test to the diagnosis. Most common genetic syndromes or epilepsy syndromes which present during childhood, like Lennox-Gastaut syndrome, GLUT1 deficiency, infantile spasms. There are a lot of syndromes are there, and mostly it's seen in pediatric age group, and many patients require thorough investigations, not only treatment, thorough investigation including genetic test and CSF. We have to keep in mind. So if you are seeing a seizure patient, if you are suspecting a epilepsy syndrome, so few things we have to be very careful asking them. Types, whether it is a single type or multiple types. Many times there are multiple types of seizure. Is the seizure starts, what causes this seizure, and the factors, what are the EEG changes, if there is an MRI changes are there, and lastly the genetic things we have to ask whether we are diagnosing a case of epilepsy syndrome. We have to be very careful in asking all these questions to them. I will speak about few epilepsy which you are seeing routinely in. There are epilepsy syndromes are there. There are multiple genetic causes of epilepsy. I will tell 5-6 most common epilepsy which we are seeing in our patient. These are not difficult to diagnosis, but there are few points we have to be kept in mind. First is the nocturnal seizure or nocturnal frontal lobe epilepsy. Many patients are coming with this type of seizure. History is like
patient will sleep at night and around midnight, they will make some sounds and relatives will saw that there is violent movement. Uh, Many times the patients don't know what happened at night, and sometimes they during the fast they are confused what happened. But when they present with the recurrent attack, they will come to the doctor. Most of the time, it is a nocturnal frontal lobe epilepsy, that is a autosomal dominant nocturnal frontal lobe epilepsy, and most of the time it is a genetic origin. If you do the MRI, most of the time it will be normal, and if you do the EEG, sometimes there is discharges coming from the frontal lobe. So EEG sometimes give clue, but most important is the history when diagnostic the second most common disorder which we are seeing is the absence seizure. Everybody knows this childhood absence epilepsy usually begins with the 4 to 8 years of age. So these are brief loss of awareness during the event, lasting for few seconds. Sometimes atypical absence can present longer and multiple seizure attack. Usually developmentally these are normal children, but sometimes it produce attention problem, and the cause is genetic. So if you do the MRI, it is normal, and EEG will give the clue, and most of the time the children will respond drastically to the treatment. So I have a patient with absence seizure. I will show you this EEG. This slide is slightly rotated. If you can see, this is a classical absence EEG. You can see there is spike wave pattern, 3 Hz spike wave pattern. So if you can see there is 1 second and 1, 2, 3. So classical 3 Hz spike seen in the childhood absence epilepsy. They will drastically respond to treatment. One important in diagnostic this in OPD basis, you can do hyperventilation procedure, and that will produce seizure. It is a diagnostic clue. Secondly, we are seeing in pediatric patient many lots are there with infantile spasm or West syndrome. It is a very devastating disease. Usually, sometimes it is idiopathic, and sometimes it is secondary to any hypoxic damage or genetic disorder that will produce infantile. Infantile spasm history is very, very important. If you can see the videos, it will produce sudden jerks of either flexion or extension, and many attacks per day, usually between less than 1 year or 1 to 2 years. Many patients are there, and by start around 12 months of age, and most children having developmental disability later in their lifetime. So few patients respond drastically to treatment, that the idiopathic variety or in symptomatic variety, they will respond, but not 100%, and they must have some developmental disability later in time. I have an EEG. You can see this is hips arrhythmic pattern known as hips arrhythmic pattern. You can see there is bursts of epileptic form discharges, and the background is chaotic. And this is a classical hips arrhythmia which is seen in infantile spasm. If you do the video, that times before the burst there will be jerk, and there is generalized discharges. This is same patient, this same burst suppression pattern. You see the burst of EEG suppression of background activity in between. This is classical hips arrhythmia pattern. And next common epilepsy which we are seeing in the juvenile myoclonic epilepsy. So we have to take the history very thoroughly in juvenile myoclonic epilepsy. Onset around the second decade of life, and they have typical myoclonic jerks mostly during morning. So all patients of second decade epilepsy with generalized seizures, you should take the history of myoclonic jerks to diagnose juvenile myoclonic epilepsy, because there are important points like they require lifelong medication. They will respond dramatically to treatment, but they require lifelong medication. If you stop the treatment, they will present again. In 99%, they will present again with seizure. So this is very, very important in diagnostic juvenile myoclonic epilepsy. And if you see the EEG of juvenile myoclonic epilepsy, the classical polyspike wave, you can see there are multiple spikes and waves. So this pattern is very, very classical of juvenile myoclonic epilepsy with myoclonic jerks. Category which now in Bhubaneswar I am seeing less, but during enhanced time there are a lot of progressive myoclonic epilepsy in pediatric age group. There is a publication of 100 patients of PME syndrome. There are a lot of PME syndrome. There are also very devastating disease, frequently associated with loss of or regressions of milestone like motor skill, language, and cognitive function, associated with myoclonic jerks. So, history of myoclonus associated with regression of milestone in the pediatric age group. Always keep in mind of progressive myoclonic epilepsy syndrome or PME syndrome. There are many PME syndromes are there. Mostly we are seeing in Bangalore Lafora body disease, or sometimes this Longos disease, and few patients of child disease also we have seen. So 3-4 categories which are very common, and most common is Lafora disease. And if you do the biopsy, you can find the PME syndrome is very challenging disease, and diagnosis is very important in pediatric age group. Myoclonus with regress of milestone, think of PME syndrome. And another most common disease which we are seeing that MRI is normal, EEG sometimes normal, and EEG sometimes abnormal, is the epilepsy with generalized tonic-clonic seizure alone. These are new terminology is used, usually seen in the adult age group. Sometimes there is family history. Most of the time it happens during awakening. But is not associated with myoclonic jerks as in JME, but it happens in the early morning time. And common triggers which causes the seizure are sleep deprivation, alcohol, fever, or in female menstrual period, and sometimes photosensitivity produce the generalized tonic-clonic seizure. These are a category of IgE syndrome, that is idiopathic generalized epilepsy. So most of the time it is a genetic. If you do the MRI, it will come as normal. They will also respond dramatically to treatment. Most of the time myoclonus is absent, which differentiate between the JME. You can see a patient with IgE syndrome. There are generalized discharges. You can see in the EEG. So these are patients with IgE syndrome with. The other variety which we are seeing in pediatric patient most of the time and few adult patient, which is new onset super refractory or refractory seizure, that is fires. That is sometimes it is associated with fever, and it will produce recurrent or super refractory seizures. In most of the time it is children, and these are very devastating disease. Many times children will stay long in the ICU and long treatment, and they later will present with lot of disability like motor regression of milestone, cognitive, language, and many symptoms they will present. Also they will develop chronic epilepsy. Many patients, almost 12 patients we have seen, whose children are absolutely normal, and it starts around 4 to 8 years of age, and they will later turns into a epileptic patient with refractory seizure. So this terminology also will keep. Another most common, also very devastating disease is Lennox-Gastaut syndrome. History is very much important, whether it is a symptom, and they most of the children having developmental there is a global developmental delay. So history is very important. Also in EEG, there is classical less than 3 hertz, around 2 to 3 hertz spike and wave pattern syndrome. And but you have to rule out genetic and metabolic studies to rule out any other causes, and most are very refractory to treatment. Other common category which here very less common in Bhubaneswar, but in Bangalore we have seen lot of epilepsy, especially in southern India. Hot water epilepsy is very common in Karnataka and Tamil Nadu. People will present with history of hot water bath in the morning, and in bathroom only they will fall down, and there will be generalized tonic-clonic. There are a lot of publications on hot water. Most of the time, if you take the history of what happened during the seizure, what is the trigger, you will get the history of hot water bath. And if you can avoid that trigger, most of the time the patient will be seizure free. They don't require any treatment. But history is very important. Sometimes there is photosensitive epilepsy, photosensitivity to mobile flashlight or TV flashlight, it will also trigger the seizure. So you have to be very, very careful when you are seeing a patient with history. Reflex epilepsies are also very, very common. You have to avoid that reflex. And the last and the most common epilepsy which we are seeing in our OPD is temporal. They are most common form of focal. Most of the time the cause is unknown, but the possible causes are there is childhood onset of any trauma that will reach rise to temporal lobe epilepsy, and history is very, very important. Temporal lobe epilepsy, sometimes they will present transient loss of awareness with some automatism movement, and most of the patient will respond to medicine, but few patients also will require surgery. So this is a case of temporal lobe epilepsy. If you see the EG, you can there are discharges in left temporal lobe, also in left centroparietal lobe here. So and other part it is normal. So these are very classical focal abnormalities in the left temporal lobe, and that patient, if you see the MRI of that patient, you can see, there is classical coronal flare MRI sequence. You can see bilateral very clear cut finding. You don't, but you have to do the coronal flare MRI to clearly identify the hippocampal sclerosis. This is a very important imaging finding. For all epilepsy patients, we must have asked few questions before proceeding further. What is the onset of the seizure? Taking the history, whether it is a focal onset or a generalized onset using an 80% confidence level. If you are not confident, you label as onset is unknown. Second thing is whether that time the patient is aware of the surrounding or not aware of the surrounding. That will give clue whether it is a focal onset or generalized onset. Third important thing, whether there is any motor movement was there or there is non-motor symptoms, then you inquiry about sensory symptoms, you inquiry about automatism, you inquiry about autonomic symptoms, all these symptoms if there is non-motor symptoms. Then the clear-cut point which is very important, what is a bilateral and what is a generalized. Generalized means the onset simultaneously in both hemisphere, that is generalized. Bilateral means onset in one hemisphere and spread to other, that is bilateral. So bilateral and generalized, when we are using the term of generalized onset or bilateral, means we have to clearly differentiate whether it is onset one lobe and spreading to the other. Then when we are seeing clearly, I told what is the epilepsy and how to apply. We are investigating a case of epilepsy before told the treatment in a.
Santosh, we have to wind up.
There are 4 or 5
slides. In a few slides.
Sir, 5 slides. 5
Okay.
So all the routine investigations like to rule out metabolic causes, blood sugar, electrolyte, toxicological screening, then metabolic genetic testing. Autonomic workup is a very, very important. Then imaging. So blood investigation, I already told. CSF study is very, very important. Then autoimmune encephalitis workup in new onset seizure is very, very important. And EEG, the most common thing I already told. Most common used investigation, but you have to very, very careful in identifying the correct waveform and abnormal discharge. Beware of the ECG artifact, which is a close mimicker of spikes. Careful identify the physiological EEG changes like hyperventilation, slowing, photoparoxysmal, because it will lead to false diagnosis of epilepsy. The proper activation procedure. MRI is very, very important, but when we are advising the MRI, always advise proper epilepsy with coronal flare and SAS flare. Always look for T1 MRI anatomical variations. Contrast and spectro is not important. Then advanced investigation when we are diagnostic epilepsy, SPECT and MEG is also very commonly used in post localization as a pre-surgical. So I am showing this few EEG. This is a case of myoclonic jerks. There are triphasic waves. This is a metabolic cause of abnormality. You can see there is triphasic waves of uremia. And there are patients presented with focal seizures. When you do the contrast MRI, there you can see focal abnormality in the brain. This is a case of CNS tuberculosis. These cases are presented with psychogenic seizures treated as psychiatric symptoms, later turned out to be NMD, NF, encephalitis. You can see there is bilateral temporal lobe signal. And it is a case of refractory seizures. When you do the MRI, they can see the bilateral thalamic swollen and signal changes. Case that is in children. Also very commonly ischemic stroke with present with seizure. Two cases are there. One case is recurrent seizures or myoclonic jerks with cognitive loss. This presented when you do the EEG, you can there are episodic sharp waves around 1 per second, and you can see periodic. These are periodic sharp waves. When you do the EEG, MRI, you can see there is diffusion restriction in the cortex, and also there is hyperintensity of the Pitfalls jack. And another lady, when we saw this patient, a young man of 22 years, when presented with seizures and behavioral abnormality, when you did the EEG, you can see there are few focal spikes in the parietal region and frontal region left side. When you did the MRI, you can see there are rare signal changes and diffusion restriction in the left side, parietal and temporal lobe, and that area initially diagnosed radiologist as developed stroke, but you did the spectro, you can see there is a clear lactate peak. This is a case of Melas syndrome, which present with recurrent seizures, and recently we diagnosed this case. And another lady, I will just show this video. You can see this is a lady with video. You can see he is during the seizure episode. The video is taken. You can look for the eye. You can see the perioral region in the initial part. You can see the head deviation. So in this video, you can see the head deviation clearly to the left. You can see the perioral chewing movement. You can see the ictal nystagmus. You can see the right hand automatism. And there is loss of awareness. This is a ictal video of seizure. When you did the MRI, you can see there is clear-cut signal changes in bilateral medial temporal lobe. There is no diffusion restriction, which is a clear-cut point whether that is a viral encephalitis, mostly presents with destructive agents, so there is diffusion restriction. There is no diffusion, it is only later turned out to be LGI1 encephalitis. My take-home message are, when we are seeing a patient with epilepsy, always put the correct history. All seizures are not epilepsy. Try to identify whether it is a provocative seizure or non-epileptic event like syncope. Be careful for psychogenic seizure. Take the proper history. Characterize the type of epilepsy like focal or generalized. Identify the correct localizing and lateralizing signs when we are taking the history. Proper investigation like EEG, video EEG, whether short term or long term, to characterize the type of epilepsy. Imaging MRI is the best to rule out any structural causes. In unknown causes of epilepsy, whether there is MRI normal, you can do SPECT or PET or MEG scan. Most of the time, we will find a cause by genetic test to confirm the before proceeding for the. Thank you. Sorry for delay.
So it was a wonderful presentation and a very elaborate presentation with all those wonderful cases of yours, including the EEG part. So we'll wait for the second speaker to end before we take questions for you. So now, without wasting much time, I will invite our second speaker. Santosh, do stay with us. We invite our second speaker, Dr. Ujjwal Roy. Dr. Ujjwal did his MBBS in 2007 and MD in 2012 from renowned University of Medical Sciences, Delhi University. And he worked at the prestigious AIIMS New Delhi and GTB New Delhi as resident, did his DM Neurology from Bangur, Kolkata. And he's a member of many prestigious bodies, including IAP, Indian Academy, IAN, AN, and Movement Disorder Society. And he has many many peer-reviewed articles to his name and international papers, and is a reviewer for many prestigious journals. So he has delivered many lectures uh, at the national and international level, and is currently consultant neurologist at Orchid Hospital and Roy Neurocare Center at Ranchi. His important areas of interest are movement disorder and epilepsy. So I would like Dr. Ujjwal to share his screen and give us a few insights into the medical management of epilepsy. After which we will take questions from these two enlightening authors. Dr. Ujjwal.
Santosh sir, you can stop sharing the screen so that Ujjwal sir can share it.
Yes. Yes. Okay.
So you can go to the presenter mode. Ujjwal sir, you can go to the presenter mode.
Yes. Is it okay?
Yeah, yeah. Perfect, sir. Perfect. Please carry on, sir. You can start.
Okay. Thank you, Dr. Shomadarsan. Like you are always like a friend, senior, everything to me, and we have shared so many good conferences, so many good times. So it's always nice to have you as a moderator, you as a chairperson and coordinator everywhere. And Dr. Santosh has really elaborated like many things he has already discussed actually. So management, as we know from our MD days, management not only management. When we talk of management in MBBS, we used to say that yes, we have to even go to the diagnosis, then how do we treat, and then what are the fit and pitfalls, everything we have to do. So management not only includes the treatment part, but also the diagnosis part, because as we diagnose, so we manage. So diagnosis part, it has been, I think, elaborated in a very detailed manner by Dr. Santosh. So I will not go into, okay, just one second, I'll just minimize this. Okay, just. So these things already has been discussed by Santosh, Dr. Santosh, and what is the definition of a seizure, and what is the incidence rate. All those things, I think, it has been already been discussed. Only thing that here I would like to emphasize is that when we define epilepsy, why do we define epilepsy? We define epilepsy for the treatment purpose only. So if we have a single case of seizure, do we say that yes, the patient has a seizure disorder or epilepsy? So we do not, because this is actually the treatment part. So when we treat the epilepsy, when we say that yes, the patient has an epilepsy, then only we treat this patient. And when we say that it's epilepsy, we say it's an epilepsy when the patient has at least 2 episodes of seizures. We know about the definition 24-hour apart 2 seizures. And then one more thing, if 1 episode is there, then we have to have some EEG feature or some predisposing features, like the patient has a known congenital abnormality or maybe some congenital cause, some known disease which is known to predisposed with seizures. One thing, either the MRI is abnormal or the EEG is abnormal, or the patient has some factor which which classifies the patient to be a patient of a seizure disorder, something like that. So this definitions already we have discussed. What is important is we need to always understand when we get a patient with epilepsy. Yes, this is a seizure or a pseudoseizure. A very simplified, I'm telling. So we need to understand that it's psychogenic in non-epileptic seizures, because we very commonly encounter these kind of things in clinical practice. And then if we understand, then to classify the seizure, as Dr. Santosh has already elaborated upon that. detail. Sometimes a movement disorder or something else also mimics seizures. So what we need to understand is that we have to first really think that yes, this is a seizure or not, and then if it is a seizure, then we classify it further. Sometimes there are mimickers, like as I said, psychogenic non-epileptic seizures, and then the sometimes movement disorder, some dystonia, sometimes status dystonicus. These kind of things also sometimes mimics as a seizure. Cause of seizure already Dr. Santosh has discussed. I am not going to detail. It has already been elaborated. And now coming on to approach of the patient. When we get a patient of seizure, what things we see that yes, what this patient should have, and what things we need to understand when we. So first thing, and one more thing very important that Santosh already discussed, Dr. Santosh already discussed, was that we have to differentiate it from a syncope. It's a very common thing. We get very commonly patients with syncope, with loss of consciousness in our OPDs. So we need to understand that yes, whether it's a syncope or not. So the difference between syncope and seizures. So I'll go straight away to this syncope and seizure. So in syncope, the thing is that we have a, the episode is a bit less, time, and the duration is a bit less. So less than 1 minute. One thing, it's just for seconds, and the seizure is actually for minutes. Then transition to unconsciousness. So it's gradual over seconds in syncope, and in seizure, it's often immediate. Now, in syncope, generally patient stands. When the patient stands from a sitting position, sometimes when he is stands from defecation, this Valsalva maneuver, because it's always dependent on the hemodynamic state of the patient, because actually in syncope the basic pathology is that the blood doesn't reach the brain, and due to that sometimes there are heart blocks. We commonly see patients with falls who come into our OPDs or maybe ER who present with syncope and loss of consciousness. So they are referred to us, they are admitted under us, but actually due to some heart block sometimes, or sometimes due to postural hypotension. Sometimes Parkinson's disease patients, MSA patients who have hypotension comes to us with a pre-diagnosis of seizure. Someone has seen in periphery, and then they come to us with, but that's not a seizure, that's a syncope. So that's very important sometimes to differentiate between seizure and syncope. Once we differentiate it, then we come to examination. So first is the history. So in history, what things we can get. So as Dr. Santosh has already told, that if it's a complex partial seizure, the differentiation is now the classification is a bit different today. Today the seizures classification is not, we do not talk of directly of complex partial seizure, but I am going to the old terminology only. So in complex partial seizures, we have like sometimes we have with automatism is there. So we may have automatism, as Dr. Santosh has also shared some video, I think, in that. So complex partial seizure may be temporal or extratemporal. That's the classical teaching that we have from our residency days. So if it's complex partial seizure, whether it's temporal or extratemporal, that we need to understand. Temporal has a classical feature, as we know, that there is some aura, then there will maybe head turning to some one side, and there may be some tonic posturing may be there, and aura may be of different kinds. So when we talk of temporal and extratemporal, there are different findings regarding to aura, and then the semiology of the epilepsy. So this, why I'm stressing upon this much in management part, is that when we treat these patients, it's very important to understand that this is the semiology of the epilepsy. Semiology is very important because suppose a patient comes with focal epilepsy, so we need to treat with anti-epileptics who work well in focal seizures. Suppose we treat a focal seizure with ethosuximide, then it's not going to work actually. So this is very important to understand. So when a patient walks to any clinician, the important thing is that to understand what is the semiology of the epilepsy. So axis, as we said, there are different axes of epilepsy. Other axes I'm not very much concerned because but the most important thing here is that what was the semiology. So when we describe the epilepsy itself, it tells the whole story. So the history part is very important. As I always say in neurology, history taking, examination, those things are still more important. And my teachers used to say, Dr. Shamal Das used to say that even 100 years after this, the clinical part would be always important in neurology. Clinical is always important. So the semiology is very important, taking the history, how the patient had seizures, what was the predisposing event was there or not. These things are very important. Then when the patient comes to you, then you examine the vital signs, respiratory, cardiovascular support, treatment of. Now suppose a patient comes to you, you examine, and there is there is a low blood pressure with this patient. The ECG, the EKG shows some blocks, and if the patient has like if there is some atrial fibrillation, something like that, or trifascicular block, complete heart block, something like that. So you can think that this patient is not of seizure, this is syncope. So examination is very important. In seizure, sometimes my guru used to say that in seizure, what you will examine. This was his favorite question. In say patient comes to you with a seizure, so what you are going to examine? Everyone would be very much surprised that patient has a seizure, patient has a idiopathic generalized epilepsy. What are you going to examine?
Ujjwal, your voice is not audible.
Hello.
Okay, yeah. Now it's audible.
Audible now? Hello.
Yeah, now it's audible.
Okay, thank you. So Dr. Nayak could agree to me that we see number of cases where the actually diagnosis is not epilepsy, it's something else. So we need to first rule out. That's very important. And then examination is also important because sometimes some associated abnormalities, like a patient comes to you with some dystonia, with some cave ring, and patient has seizure. So you can diagnose this is a Wilson disease. So you will give, and you may give the anti-epileptics, but apart from that, you need to treat the Wilson disease with chelating agents and all those kind of things. So already I have discussed these things. If there is history of prior seizures, then we need to identify the cause. Sometimes there is seizure in some periphery when patients are given some anti-epileptics like phenytoin or levetiracetam, and patients to take these kind of anti-epileptics and remain in a asymptomatic state. And patients land up to us in maybe 1 year, sometimes even 1.5 years. Last week I had a patient with infiltrating glioma who was treated by a peripheral physician with some anti-epileptics. He presented with seizure, but he did not have an imaging. So imaging, these kind of things are very important when we deal, because we need to understand that what is the cause of epilepsy. So underlying cause, identification of underlying cause, and whether the therapy is adequate or not. That's very important. So already we have discussed this, the whole algorithm we have already tried to discuss. So patient comes with seizure, we have the history, physical examination, we have to exclude syncope very commonly, transient ischemic attack, yes, that's also very common. Migraine, yes, sometimes migraine, occipital, some auras have in migraine also, and sometimes in epilepsy also. So how do we differentiate that? So in that, we, as the classical team, we have like some shining light kind of things in occipital epilepsy. In migraine, we like some black hole, something like that. Sometimes acute psychosis also behaves as seizures, but again, I'll tell you, temporal lobe epilepsy, extratemporal lobe epilepsy, especially extratemporal lobe epilepsy, sometimes there are weird findings. I have seen patients with jumping, with some foot movements, some leg movements, erratic leg movements, extratemporal epilepsy, especially frontal lobe epilepsy. These patients have, these kind of, weird features, some weird features, which actually may point towards a PNES, that is psychogenic non-epileptic seizures, but these are actually extratemporal lobe epilepsy, frontal lobe epilepsy. And then if there is a history of epilepsy currently treated with anti-epileptics, we have to assess the adequacy of anti-epileptic therapy, the side effects, serum levels. We have to consider the lab tests like CBC, electrolytes, calcium, magnesium, serum glucose. Sometimes patients present with hypoglycemia. I had a patient just 1 month back who had a patient. I got a call from the ER. I was present in my hospital only. I got a call from ER that patient is having epilepsy. We have given already the levetiracetam. We have given the phenytoin, but patient's epilepsy is not, so shall we intubate the patient and give midazolam? So I said that, okay, this patient is diabetic or not. So they said that resident to do the sugar levels. It was just relatives with neighbors. They did not know that this patient was already a diabetic and taking, anti-diabetic medications. Patient had a hypoglycemia. So that's very important. Glucose is just one step. We have rapid, glucometers nowadays. So we can, serum glucose very important. And then toxicology, screen, urine analysis, those things are very important. And if these things are normal, then whether we are treating correctly or not. So that's very important. The patient is compliant or not. Compliance is very important. When we talk of practicality, patients will tell you that patients are taking drugs, but believe me, they are not taking. Compliance is very important. The patient who is controlled since last 3 years, patient has all electrolyte normals, everything is normal, MR has no changes, EEG is normal, patient CS, and with tongue bite, all those things that comes to you, you definitely ask twice that you have to speak the truth. You have not been. As I said,
yes, your voice is back.
Yeah. So if there is no history of epilepsy, again we go through the same things. Only that if the negative metabolic screening is there, then we go for the MRI scan and EEG, and focal features of seizures, focal abnormality on clinical or lab, and then if it is positive metabolic screening, which or symptoms or signs suggesting a metabolic or infectious disorder, then already we have discussed some of these things, but some points to add here, like alcohol blackouts, delirium tremens. Sometimes these things also may mimic a seizure. And psychogenic, already we have discussed syncope, already discussed migraine, already discussed TI, already I have told. Sometimes sleep disorders like narcolepsy, cataplexy, all these kind of things also may mimic the seizures. Movement disorder, I have already enumerated some things. I have some videos also. If time permits, I'll show those videos. And special consideration in children, very important thing, breath holding spell. These are sometimes very, very for the family. Actually, they feel that what is happening, and they are running from here to there with diagnosis of epilepsy with many anti-epileptics. But you really need to understand that this breath holding spell, if you diagnose, these are very benign things. You need to reassure the patient. You need to reassure not the patient relatives and the patient's parents that breath holding spell is just about reassurance, nothing else. Sometimes migraine with recurrent abdominal pain and cyclical vomiting, we know, and apneic spells, as we know. Sometimes like parasomnia, night terror, and sleepwalking. We have already discussed this. Now coming on treatment. This was the diagnosis part. That's very, very important. As I said, starting from the semiology to the labs, to the MRI, to the EEG, everything is very important when we talk of treatment. When we talk of drugs, why? I'll come just after 1 minute or so. So when we talk of therapy for a patient with seizure disorders, almost multimodal and includes treatment of underlying condition, as I said, and avoidance of precipitating factor like alcohol is very important factor. And majority of the seizure precipitation and breakthrough seizures, as we say, it is due to sometimes alcohol, sometimes due to some other factors like decreased sleep, these kind of things. Suppression of recurrent seizures by prophylactic therapy with anti-epileptic medication of surgery, or surgery is the later part. But before that, we need to understand that what is the cause of this. Sometimes psychological and social issue also needs to be taken care of. Like we see women with epilepsy, very important things. When we these patients, especially young women who have epilepsy, marital issues are there. We know very well these kind of things. The last in academic IN, I think 2 years back. So this was the focus, that women with epilepsy, what we need to do, how we need to proceed. And I think Dr. Gagandeep has done a very good kind of Gagandeep sir has taken a very good initiative to some marital counseling of these kind of females who have epilepsy. That's a great effort. And then the treatment plans, and definitely the person who is experiencing epilepsy should have this, because I'll come to this later why this is the thing. And these are the anti-epileptics available, we all know. So starting from bromide in 1860, this was the first anti-epileptic, to phenobarbital in I think somewhere around 1915 or so, then phenytoin in around 1930, in 1930s, and then ethosuximide, primidone, then the benzodiazepine, carbamazepine, sodium valproate, and then vigabatrin, jonisamide, lamotrigine, felbamate, and so on. So I'll not go into this detail of mechanism of action, just one line for each drug. So phenytoin, carbamazepine, lamotrigine, lacosamide, these are voltage-gated sodium channels. The levetiracetam is SV2A inhibitor, and the sperampanel, the new one. So AMPA receptor, it acts on the AMPA receptor. Felbamate, NMDA receptor, and retigabine, it acts on KCNQ, that is potassium channel, postsynaptic neuron. And the gabapentin, pregabalin, we all know about that. The calcium channel, the PQ type, and the GABA receptors. And valproate, ethosuximide, especially the valproate, this has different mechanisms of action, but transient type calcium channel, because it acts on the the absence seizure. It's a drug of choice for the absence seizure, the ethosuximide valproate. So that mechanism is based upon the transient opening, that is transient type calcium channel. But valproate has other mechanisms also. Why this is important to understand these mechanism of action? Because sometimes when we combine the drugs, these drugs, it's very important to understand we should not, ideally we should not combine the same drugs of the same mechanism of action, the drugs which have the same mechanism of action. Suppose we have given some patient is on carbamazepine or oxcarbazepine. So we try to avoid lacosamide in this patient, because already he's on sodium channel. So we can add some other drug. So when we talk of polytherapy, we try to combine the patients on different mechanism of action, the drugs with different mechanism of action. That is what it is. And already we have discussed when to start the therapy. So when we define that, yes, this patient has an epilepsy, and single seizure controversial, but I'll again say that when we define single seizure, some people say a very few percentage of epileptologists or neurologists have this opinion that yes, single seizure may be treated. But if the single seizure cannot be classified as epilepsy, why should we treat it? That is my thought. And yes, but if we have defined that yes, the patient has epilepsy, when the patient has some brain, some focal lesion, there is some EEG abnormality. We have classified into some syndrome. Suppose we have classified that yes, this patient has a JME, only one. Then if the patient has JME, juvenile myoclonic epilepsy, some feature on the EEG, or we have some generalized spikes, we have some photic response on the EEG, we have some those kind of features of myoclonic epilepsy, then we may have we may treat this patient, and then actually that patient classifies into an epilepsy. So that's very important. When I started this talk, I said that epilepsy diagnosis is important. So I'll not take much time on this. The risk of seizure recurrence in a patient with an apparently unprovoked or idiopathic seizure is uncertain, with estimates ranging from 31 to 71% in the first 12 months after an initial seizure. So this is a line which every patient needs to understand. When they say that is दवा को नहीं भी खाएंगे तो क्या चलेगा, that is always a question when we start these patients and they come to us after 6 months, 8 months. They think that why they are taking this medication when they are well, when they can stop these medications, and they stop this medication chupke se. That is where compliance is important, and then this patient have seizures. And initial approach and targets of treatment differ considerably. As I said, most common form of epilepsy like absence epilepsy or focal epilepsy, and severe epileptic encephalopathy. So the total paradigm of treatment would change in this. And where these kind of small like absent epilepsy, we need to just give some anti-epileptics and these patients may be controlled. But where we have severe epileptic encephalopathies, we have multiple anti-epileptics, still patient has seizures, and sometimes patient has other disorders also apart from epilepsy, like cognitive impairment and movement disorder, all those kind of things. Yeah. And what are the risk factors associated with the recurrent seizures? So already I have discussed this, but still inside abnormal neurological examination, seizure presenting as epilepticus, post-ictal thought paralysis, a strong family history of seizures and abnormal EEG. That's important. Poorly controlled epilepsy, we should rule out pseudo-resistant. That's very important. So the patient who has been treated, with some periphery, he has been treated and comes to us. So we need to understand that yes, this is seizure mimic or something else. So it's a seizure or seizure mimic, as I said earlier also. Sometimes incorrect classification. Suppose in primary generalized epilepsy, if we give carbamazepine or phenytoin, it's not going to work. Sometimes wrong dose. I have seen patients, I have seen in my residency days, and when I was a resident in Guru Tegh Bahadur Hospital, University College of Medical Science, I was a senior resident there in neurology. So I used to see that patients are coming with from medicine ward, some valproate 200 mg/BD. Patients are controlled also. They are doing well. No, I'm not talking of JME. First episode, patient has a GTCS through 2-3 episodes. Patient is started on valproate. And what is the dose? 200 mg/BD. Patient has maybe 50 kgs. So I think that dose was low. And patient is having seizure again and again. And patient is coming to us. Should we change the medication? Is the diagnosis correct or not? That's not the case. Actually, the dose is low. Dose is very important. In all, especially in the children, dose is very important. But even in adults, we should understand that sometimes the patients are very heavy, very hefty. Then dose needs to be more. That's what I feel. Then poor compliance already I've discussed sleep deprivation already told, alcohol recreation already told. Now selection of anti-epileptic. This is a very important slide. So in GTCS, like we have first line like valproate, and like alternatives nowadays, I think in levetiracetam there was some this paper from NIMHANS. Now they have said that study was there from already. They have published from NIMHANS. Initially, earlier we used to. like jonesamide, phenytoin, levetiracetam, carbamazepine, oscarbazepine, topiramate, and just complete the list, primidone and valproate. And in focal, as already I have discussed, carbamazepine, oscarbazepine, and again levetiracetam, phenytoin, and so on. In typical absence, we have valproic acid, ethosuximide. Now, the India, they are marketing this drug. Earlier, it was not available. And valproic acid is there, and lamotrigine also in typical absence we can use. But I think, in my experience, valproic acid and ethosuximide is quite good enough. The addition drugs may be clonazepam also. And in atypical absence, like myoclonic epilepsy, atonic epilepsy, we can use valproic acid, lamotrigine, topiramate, and alternatives like clonazepam, felbamate, clobazam, rufinamide can be used. And what are the variables that affect initial AED selection? So, spectrum of efficacy 1, second is adverse effects. Suppose in an elderly patient, suppose in a patient with pregnancy, we cannot start with valproate, even if the patient has JAMI. Even if the patient has GTCS coming with GTCS, patient has, so we cannot give the valproate. If at all the patient has to be started on, we can give levetiracetam. So it's very important. The adverse effects are very important. A patient who has a history of rash with carbamazepine, we cannot give oscarbazepine in partial seizure. We have to think something else. A patient who has some cognitive decline, some behavioral abnormalities, an elderly patient, we cannot think of levetiracetam. We have to really think that twice, that yes, shall we give levetiracetam or something else? So these are very important aspects when we decide a patient on what AED we should start with. Then teratogenesis already I have discussed. Pharmacokinetics is important. Especially the patients who are admitted to have multiple sickness and all. So in that we need to understand the pharmacokinetics, very important, and interaction potential, as I said, like they have, there is enzyme inhibitor modifiers, like, so in very well know that valproic acid inhibits, and it others does the opposite thing. So interaction potential is very important when we combine these kind of drugs, and when dosing frequency is also very important, and formulations, cost, availability, all these kind of things. And as I said, age, then gender, pregnancy, potential comorbidities, co-medication. Suppose a patient comes to us with a history of increasing weight. Patient has some increase in weight 10 kgs. He's taking valproates. Patient is young, female. So we need to understand that yes, I think I need to change the drug, something like that. So coming on to this slide, very important slide again, rational prototherapy. Are specific combination useful? So what are the good combinations? So valproate and lamotrigine, it's a very good combination. But lamotrigine, in my experience, lamotrigine has a very bad thing, rash. And Steven Johnson, I have seen many cases, at least 5 cases I have seen in my life, where there were something like very severe reaction with lamotrigine. But still, lamotrigine is very good drug otherwise. Then valproate and clonazepam, I think every neurologist would have used this drug. Sometimes valproate and levetiracetam, yes, and lamotrigine with topiramate, yes, though less used, but we use topiramate as a drug with primary generalized epilepsy, or GME. In GME, as we all know, it's very important. Valproate, we use valproate, and then the levetiracetam as the second choice. As per my choice, it's levetiracetam. Then coming on to partial focal epilepsy, carbamazepine and clobazam, then carbamazepine, levetiracetam and clobazam. These are very common combinations that any neurologist would have used. What are bad combinations? So as I said again, that phenytoin and carbamazepine or carbamazepine. Why we do not combine these drugs? Because the same mechanism of action. That is what it is. And then things like breviracetam, carbamazepine, clobazam, clonazepam. So, like, what are the trade names? Then what are the principal uses? Already we have discussed many things. So many doses I'm not going to detail. Carbamazepine, we are using tonic-clonic focal onset, as I already said, clonazepam absence, atypical absence, myoclonic seizures, ethosuxamide absence. Clobazam we use in many, not only Lennox-Gastaut, just a common, yeah, and again gabapentin, lacosamide, lamotrigine, levetiracetam. Some side effects, if we really want to, do we have time? Time is there or not? Okay, because already we are running short of time.
Okay, we can wind up after that.
Just finishing 1-2 slides. I'll show one video just on. That's all.
Okay, no
one or
problem.
two videos I'll show. One or two videos. Okay. Now, initiation and monitoring of therapy. So, goal is to prevent seizure and minimize side effects. And the thing is that most anti-epileptic need to be introduced relatively slow. But there are some anti-epileptic like levetiracetam. We can start with the normal. We need not titrate the drug. So suppose in carbamazepine, we know from the very residency days that we need to slowly go up carbamazepine. So in levetiracetam, we have that liberty. We can directly jump to the recommended dose. It varies from drug to drug. So we need to understand that how we need to introduce this drug, then how we need, if there is some other drug already, the patient is already taking some other drugs, then there is some other, even then we have to introduce the drug in some other, we can go still slower. That is what it is. So that there is no cognitive problem. And now this is a very important slide, every one of, like, because we have many patients who come to us that when we will be able to stop this drug or something. So complete medical control of seizures for 1 to 5 years. That's very important thing. Single seizure type with generalized seizure having a better prognosis than focal seizures. Normal neurological examination, no family history of epilepsy, normal EEG. And one more thing that I would add here, if the patient has a normal MRI. Suppose a patient has some focal cortical dysplasia present to us with FCD. So we know that this patient would have seizures if we withdraw that, even if the patient is on one anti-epileptic. So again, going back to clinics, going back to the diagnosis, if the patient has a juvenile myoclonic epilepsy, then we know that this patient, if we withdraw drugs, is a lifelong disorder, patient is going to have epilepsy at any time. So we need to counsel the patient accordingly, that depending upon the seizure type, depending upon the the semiology of the epilepsy, the diagnosis, the axis, as we discussed the axis. So in that axis, the diagnosis of epilepsy. So what is the epilepsy? So so we need to understand that what is the the diagnosis of the epilepsy. Now, if the patient has complete medical control of seizures for 1 to 5 years, and patient has does not have any focal cortical dysplasia, so in that case, withdrawal of therapy after 2 years, who meets all of the earlier criteria. So in that case, so we tell that in three years, that is the gold standard. So it has CC. So now the NCC is not there, MRI has been cleared, EEG is normal, patient has been left. So what golden rule everyone follows, and every neurologist will agree on this: 5 years of epilepsy free. There is no epilepsy for last 5 years. The MRI is more or less normal, and then the EEG is also normal. So in that case, we can start tapering off the drugs, given that the patient understands that what are the risks and what are the what can be the outcome of that. There are different guidelines actually. In this, neurologists will differ from one neurologist to other, but majority of them, what I think is that if the patient doesn't have any lesion on the MRI, no structural problems, so 3 years. If structural problems are there, then 5 years. That consensus, I think most of us would follow. In most cases, it's preferable to reduce the dose of the drug gradually over 2 to 3 months, and most recurrences occur in the first 3 months. So that's very important, that patient and patient relatives should understand that during this period, patient should always avoid driving, swimming, and patient should be under direct observation of a caregiver. And like this slide is quite busy slide, but some points are very important here. Approximately 20% of the patients have epilepsy syndromes with well-defined risk of relapse, like I said in JME, and approximately 1/3 of or to 1/2 of the patient relapse on attempted AED withdrawal. That's very important. And 20% even have seizure relapse while on continued AED therapy. That we already know. And AED withdrawal increases the risk of seizure relapse by twofold as compared to continued treatment. So these things need to be told to the patient. Sometimes patient would come. I will share this. So I have a typed thing where these kind of things are written on a paper. That what may be the risks when I am withdrawing this drug. So it's written already, given to the patient. So in that case, patient may they should sometimes say that no sir, मैं तो चल रहा है, ठीक चलने दीजिए, तो कोई दिक्कत तो नहीं है, no दिक्कत. Then you can continue with this. But yes, if the patient, you also need to tell to the patient that if the patient doesn't have any lesion, had some only mild EG abnormality was there, patient is seizure free for maybe 3 to 5 years, then the side effects, you have to weigh. The risk is to side effects. So always there is a way, you have to weigh the side effect that is happening to the patient, and the patient is okay with some drugs continuously, there is no problem. Maybe that he can continue also. If he feels that yes, I may have a seizure, withdrawal. Seizure, if the patient has a, breakthrough seizures after withdrawal of these drugs. So, and decision of AED withdrawal should be individualized after proper assessment of risks and benefits. Approximately 1/3 of the patients do not respond to treatment. Try a combination of drugs to control seizures. Patients who have focal epilepsy to an underlying structural lesions, multiple seizure types are particularly likely to require multiple drugs. Rational polypharmacy, it's many seminars, many conferences, but no clear-cut guidelines. And combination of first-line drugs already we have discussed, and then the other drugs like jonissamide, brivaracetam. And patient with myoclonic seizure resistant to valproic acid may benefit for addition of clobazam and clonazepam. Already we have discussed this. And if there is no improvement, third drug can be added. And this is GTCS, status epilepticus in adults. I think this slide is not important. Everyone would have treated this. Refractory status epilepticus, it's a totally different this. I'm not going to detail. Catamenial epilepsy around the time of menses. Sometimes patient may benefit from increasing of anti-epileptic drug doses during menses. I have two or a couple of patients where I have instructed the same, and they are benefiting from that. And pregnancy, it's a whole vast topic. Already we are studying short of time. AED and fetal malformation, I think so we need to understand that there's just one line I tell here about this AED and fetal malformation. AED in pregnancy, just one line. If the patient has an epilepsy, ongoing epilepsy, and patient comes to you with a seizure, then we need to first understand that what is this epilepsy. Suppose a patient has a tuberculoma and patient is taking this anti-epileptic drugs and now is pregnant. I have seen a couple of cases like this. In that case, the patient has a lesion in the MRI. Patient still has, and when you do the EG, there are focal spikes, spike wave discharges, and all are there. In that case, you need to tell to the patient that if you leave this drug, then you may have epilepsy. That may actually hamper the fetal listing also. If you have seizures, continuous GTCS or status epilepticus, then that may harm your fetus also. So in that case, one thing we can do that we can shift to suppose the patient is taking some drug like valproic. It may be that some periphery they have written the valproic. So in that case, we need to shift it to some drug like some levetiracetam or safer drug. Suppose a patient who has been on drug since long time and now is pregnant and is epilepsy seizure free. So in that case, the patient, you have to discuss with the patient. That's a very important thing in medical legal also, and also with regards to the patient. We need to discuss with the patient. We need to explain the pros and cons. What are if you leave this drug, then what may be the effect of that. If you take this drug, what may be the things you have. So at all, if the patient is taking some drug like valproate, there is no question you have to shift it to some other drug. That's sure. But if the patient is taking, suppose, levetiracetam, or patient is taking lamotrigine, something like that. So in that case, we need to discuss with them. Discussion is very important, and I think we should have informed consent that yes, I am taking this, and you should give it on. It should be in black and white. It should be on pen and paper, that we have explained all the risks to the patient, relatives to the patient, and patient understands the risk of taking this drug or leaving this drug, whatever it is. It should be on black and white. That is one thing that I would like to emphasize here. Breastfeeding, I think it's not very important, but yes,
we wind up.
Yes, just one slide, Soumya. Yeah. So just one very interesting fact that valproic acid, as we understand, that it's a very dangerous, but it's only 5% in the breast milk. That's very important fact actually. In the breast milk, when we talk of breastfeeding, only 5%. So relatively, it crosses the breast milk. In the breast milk, only 5% of that is secreted. That is one very interesting fact. I have some videos, Dr. Soumya. Can I show those? Just 1 minute, I'll take.
Yeah, sure.
Yeah.
Go ahead.
Just I have actually just many videos, but I'll show just a couple of them. Just 2 days back, I had a patient. Just fresh videos I'll show. Yeah.
We'll be happy to see.
Yeah. Achha, first I'll show some other one.
In the meantime, we'll ask all our participants, participating doctors, to put questions to Dr. Santosh and Dr. Ujjwal, which we will be happy to take.
Yeah. Is the screen being shared, Dr. Soumya?
Yes.
Are you getting the video?
Your screen only.
So you have to stop the screen sharing and then sharing the screen to the video, sir.
Okay.
Now the PPT is on.
You have to escape from the PPT and go back to your screen and home screen, and then from there you go to your videos and share it.
Stop share. I'm telling. Stop share already. Now what I have to do?
Now you
open the
screen sharing. Okay.
You escape,
and then.
So you open the video and then you share the screen.
Yes.
Okay. Yes. Now you can.
Are you getting the video?
No, sir. It's not running. It's not running, sir.
You have to play it, Ujjwal.
Sir, it is playing in your laptop?
Yes.
So then, sir, you stop the video. Stop the video, sir.
I stopped, yes.
Then stop the screen sharing, sir.
Okay, stop screen sharing. Okay, then.
Now play the video, sir.
Now shall I play?
Yeah, play the video first. Then share the screen to the video.
Okay, I understood.
Yeah. Now you can go back and then replay again, sir.
Yeah, understood. Thank you for that information.
Yeah.
So, any clues what it could be actually? I think not for Dr. Soumya or Dr. Santosh, for other people who are watching. I mean, just interesting kind of. This video I got just one week back from a patient actually. He was on multi. He's basically, so anyone can answer if that would be great. It was very tricky. Even when I saw this patient, so I thought that this may be a seizure because the way he's this. So anyone can. I think Dr. Soumya should not speak and Dr. Santosh, and anyone else can.
So we ask participation of the audience first. Can you replay it again? Yeah.
Yes.
So if he had any comorbidities or anything,
Yes, I'll tell. So this patient had a history of psychiatric drug, he has some abnormality, and he was having these kind of episodes intermittently, and patient was taking antipsychotic for a long actually, and he had some turning of head towards left since long, since he's taking antipsychotic. Yeah.
So now I think Dr. Ujjwal has given a very good video and some good clues. The audience will now catch up.
Yeah.
So that's his forte. He's he's an author. So anybody from the audience or
anybody?
So no responses yet.
So okay.
So actually, Dr. Soumya, I would agree. This is basically actually retrocolis here.
This is a retrocolis.
And
likely it is. Yes, Dr. Manoj has answered. This is he has told it's a dystonia. Okay, so he has rightly identified not a seizure.
True.
So this is a drug-induced dystonia.
True.
And more likely it's some tardive dystonia.
Yes, true.
Very nice.
True.
And full marks to Dr. Manoj for identity.
Yes.
Okay, so we move on. Any more videos?
Yes, one more I'll show. Yes.
And in the meantime, okay, first we'll see the video. Okay, you can keep on playing, and if any antecedent history you can give for the audience to answer.
Yes. The patient, yes. The patient had a history of fever just 12 days back, and then patient presented with these kind of movements in the home. Patient was treated with multiple antiepileptics, but patient did not respond. I do not have the EEG. Actually, EEG was there in my mobile, but somehow I'll show another video also of her.
Okay, fine.
One second. Other video is also there. Just 1 second. I'll show.
So we had some nice videos by Dr. Santosh. He gave 1 or 2 videos. So those were very nice actually. One of the lady with some tonic neck deviation. So one classic one. Oh, wonderful.
This just presented just 2 weeks back to me.
Okay.
Yeah. Only fresh videos I'm showing, not showing old videos.
Okay. Very nice. So anybody will guess from the audience, or we'll allow Santosh to decipher? He had deciphered it earlier for his patient.
Yes.
So he will decipher this for us also.
Yes.
It's a very nice video, very classic.
Patient showed to one neurologist actually. So she was given levetiracetam.
Okay.
Then showed to another neurologist. Valproate was added.
Okay.
And then again to show to a neurosurgeon. So phenytoin was added. So she is already on these 3 drugs.
Okay. Fine. And there was no fever.
But unfortunately, patient was advised for MRI.
Yeah.
MRI was not done. Only CT scan was done actually. I do not have the MRI. I'll show sometimes later actually. Actually, this laptop is not mine actually. I have all the MRIs on the laptop actually.
Oh, hyponatremia. 3% ऐड कर दे और लोड कर दे फेनिटोइन ने फोसोलिन ने लोड कर दे और फोसोलिन 8 आवरली कर दे है ना हाँ एमआरआई काली पाइन है ना रात्रि लोराज़ेपाम दे दे ठीक है लोराज़ेपाम की मिडाज़ोलाम दे दे कहले मुझे भी देखिए पे ना काली सकाळे देखि दबा हो ठीक है तू दे दे 3% दे दे हेलो ना मैनिटोलोमिट कर दे हेलो और काली एमआरआई करा ठीक है हाँ अन्य रिपोर्ट्स गुड़ा मते अपडेट करियो मु सेमिनार रे अछि मु फॉलो कर चुके okay so anybody okay so we have this very nice video with oh sorry
So this is basically this I'll tell you what the small history. The patient had a fever around 2 weeks back. Then she started having these kind of movements continuously. She was having after 7 minutes again and again.
Right.
Refractory epileptics added, no effect at all. So patient presented to us in casualty with status epilepticus now.
Right. So she's in a partial status, and we can see classic movements of perioral lip smacking movements, and we can see some focal motor movements and carphologia. She's picking on clothes. So these usually indicate some temporal lobe features. So more likely she may be, we have to look into the MRI for some, either it may be some NMD or limbic autoimmune encephalitis.
Also, already you have told the diagnosis. So we did the MRI. I'll show you the MRI sometimes later. And we sent the CSF and all tests. So it was NMDA receptor type positive, yes. NMDA.
Okay, very nice.
So we gave the IVI this methylprednisolone. First 2 doses, no response at all. So we gave IVIG. Patient responded very well.
Okay.
Patient comes to now. Yes. So yesterday only patient came to me in OPD. She responded so well. She was discharged in just 1 week actually.
As Santosh had rightly pointed out, these patients fallaciously, or actually they fall first into the psychiatrist, then the neurosurgeon's hand.
Yes.
Because of the psychiatric features.
Yes. And the neurosurgeon, they added the phenytoin. There is no effect was there actually. They did not order a MRI. Earlier, the neurologist had seen he had ordered MRI, but she did not do the MRI actually. So when we did the MRI, there were classical features actually.
Okay.
Yeah.
So any more videos?
Already time is not permitting.
Okay. We have one question from Dr. Patisha. We'll ask Santosh to take that question. Dr. Patisha wants to know whether AD is indicated in recurrent seizures with metabolic abnormality. Santosh, will you come to the screen? Yes. Dr. Patisha wants to know from you whether you advise AD in recurrent seizures with metabolic abnormalities.
No, metabolic abnormality means which metabolic abnormality? If it is a reversible metabolic abnormality like hyponatremia or hypoglycemia or hypocalcemia, we can treat the metabolic cause. In that case, long-term seizure, anti-seizure medication is not required. But if it is a metabolic abnormality like genetic metabolic abnormality, in that case, anti-epileptic is must, because many times the cause of genetic metabolic disorder treatment is not there. Unless some diseases like pyridoxine dependent epilepsy where pyridoxine is available, or glutathione deficiency where ketogenic diet we can give. In that case also we will add anti-epileptic along with primary treatment. But otherwise reversible metabolic abnormality, very brief course, otherwise long-term anti-epileptic is not required.
Actually, she had asked for electrolyte deficiency, electrolyte abnormalities.
Not required for
Not required. Very nice. So, very nice presentations by Dr. Santosh and Dr. Ujjwal. Actually, we had the take-home message that you have to first find out whether it's actually a seizure or a seizure mimic. Both the authors have identified many things which you must rule out: syncope, TIA, PNES, movement, sleep disorders. And then you have to find out whether it's a provoked or an unprovoked seizure before you start treating. And if it's a provoked seizure, follow the guidelines, give treatment for the cause, and you have to give anti-epileptics for a short duration, as we have already reiterated. And then if you see that it fits into an epilepsy or a seizure, first you have to identify whether it's a seizure or not, and then you have to see whether it's an epilepsy or not. If you have some abnormality on EEG, MRI, and if the semiology of the seizure fits into some epilepsy syndrome and it's an epilepsy, you define it as an epilepsy, then you start treating it accordingly. So Dr. Santosh highlighted many things, among which were investigations, very nice EEGs, and he outlined many syndromes which were interesting. Hot water epilepsy. Santosh, how many cases of hot water epilepsy you have seen?
Almost 50 to 100% in NIMHANS. In epilepsy clinic, almost 10% are hot water epilepsy, and in NIMHANS, Professor Sanjeev Sinha used to show videos during his residency, because his thesis may be on hot water epilepsy under Professor P. Satish Chandra. Then how people, they will take to bathroom and they will pour hot water and they will develop seizure. Nice videos are there. So means a lot of research.
I think that Dr. Santosh, study about levetiracetam, that levetiracetam now we can use in, they have done a very large randomized control trial with regards to levetiracetam in status epilepticus. So that, I think that study Dr. P. Satish Chandra only was doing, yeah, I think, yeah.
Actually, in that one of my, if it is a recent study, one of my friend, Dr. Devavrat, he did study in status comparing levetiracetam and valproate in elderly status epilepticus, where a lot of comorbidities are there, and he found that levetiracetam is equally effective to valproate in control elderly status.
That is what.
Very nice. Actually, we had Dr. Satish Chandra telling us. Yeah, we had Dr. Satish Chandra telling us that in OPD they have a separate room where they pour hot water.
OPD is also there, sir. OPD, there is also there.
Yes.
That time maybe there, now means OPD has changed, lot of things have changed. But videos we have seen, sir is pouring hot water and Professor Sinha is recording video. These videos we have seen.
So actually very nice actually, Santosh, your presentation. And Ujjwal, Dr. Ujjwal rightfully highlighted the ABCs of management, including to identify the known causes, electrolyte abnormalities, and single seizure, whether to treat or not to treat, better to err on not to treat rather than treat, and the patient variables which are important, that is efficacy, cost effectiveness of drugs, semiology, and to identify the syndrome especially, and also to look for whether the patient is pregnant, whether it's an elderly patient, or whether children or special population. And also highlighted the need of rational polytherapy. So if we have any more questions, and he highlighted the drugs for each syndrome complex and also for the type of seizure. So if we have any more questions, otherwise we will wind up. And before
No questions. No questions, sir.
no more
No
questions.
questions. Yeah.
Okay. So before I wind up, so I'll just show one or two videos pertaining to whatever things today our authors taught, our speakers taught. So this is my experience. Is my screen shared?
Yes, sir. Yes,
Okay.
sir.
Yes, yes.
So this is one thing which Ujjwal had already presented. So yeah. So just observe, there's an elderly gentleman. He presented with, I'll just describe, right-sided focal motor seizures, and it was continuous. So it was a partial status. And as he said, he asked his resident to look for the sugar levels. This fellow's sugar levels were more than 500. And we treated the sugar levels. So this was a provoked seizure. And this is the second case. This is an elderly gentleman. Already Dr. Santosh has provided, but this is an old video, not a very new one. He had very slow myoclonus. Elderly gentleman, 70, presented with progressive dementia over 2 to 3 months. I saw him way back in maybe 4 years back. And initially, we were not able to catch the syndrome because his MRI, initial MRI was normal. But this was his second MRI, which we did. So I would request the diagnosis. And this was his EEG. So Santosh?
EKG like EEG. EKG like EEG.
Yeah, it's CJD. It's CJD. There's classic cortical ribboning. It starts from the posterior aspect and the triphasic waves. So again, this is a female patient, and we already have discussed. So she had presented to us with status, and already we have discussed the drugs for female patients. Most safe drugs for female patients, in your opinion, Santosh, which drugs would you prescribe for pregnant females?
I am prescribing levetiracetam and lamotrigine.
Yeah. So that is, I think, Ujjwal, you'd agree. We'd go with
Yes,
Lev and Lam.
Already I said
Recently, I read an article of oxcarbazepine because one of my junior, he's pediatrician, his wife having recurrent episode of complex partial seizure.
Yeah.
So he came to me that we are planning for pregnancy.
Yeah.
So when she had multiple seizures, I prescribed oxcarbazepine. I stopped levetiracetam, I stopped valproate, and her seizures were very well controlled, no seizures. Then he came for planning for pregnancy.
Okay.
That time when I review, they are telling, even in Continuum, they have published the article, oxcarbazepine, if the person is taking and well controlled seizure, you can continue oxcarbazepine in the first trimester of pregnancy without many adverse effects. So we have a belief that carbamazepine or oxcarbazepine having specifically oxcarbazepine, not carbamazepine. So we can use. So I started in the second trimester again. In the first trimester, during my fever was there, so I continue with levetiracetam 1 gram BD, then change to oxcarbazepine. And now the baby is also absolutely fine, 1 year old now.
So that's a very nice indication. Actually, carbamazepine also, if you are using it as a single drug in pregnancy, it has been deemed safe. So even if you are using valproate at a very low dose, given all the apprehensions, we had Dr. Sanjeev Thomas. I think Santosh attended that lecture. He said, even if you give it at a very low dose, then it is deemed safe in pregnancy also, but provided you use it as a single agent. So I think it is a very valid point that you can use.
But in clinical practice, if you do that, then you can bang your head sometimes.
So I'll end it up with this last video. This is a young child with frequent eye blinking. and you will mark one sudden jerk. Yeah, and his head falls down. So, any diagnosis? So we won't go into more videos. So I'll stop here. I have a
SSP to rule out, sir.
yeah.
That child video may be what is there, sir? SSP to rule out, I feel. Or my
No, not really.
Yeah, that's a myoclonus, and he had frequent eye blinking. It's a case of
that is Gibbons syndrome.
Myoclonus with
syndrome.
with frequent eyelid blinking.
yeah,
Gibbons.
it's Gibbons syndrome.
Gibbons.
So he was just a spotter in the OPD. So this is just
You
for
can give it to the first second year residents, your residents. They will feel very, very happy to see this, because
we are doing this for our exam going children. Sorry, for
Yes.
our exam goers.
yes.
So DM residents. So I
Epilepsy with eyelid blinking. Like I had seen only one case, but I could not record in that.
we catch these cases in OPD.
Okay.
Okay, so it was a very nice discussion and a lengthy discussion, but we had an elaborate one. And I thank the INTAS people for allowing us the time, and two eminent speakers to take up the topic, and we discussed thoroughly. And I thank Dr. Michael and his entire team, Chinmay. We would like to wind up the session. Dr. Michael, please.
Thank you very much, Dr. Santosh, for your very elaborate and wide spectrum discussion on the various epilepsy syndromes, and also Dr. Ujjwal for your very elaborate session on the medical management, which started from the very ABC of diagnosis right down to the management of all the molecules past and present. Thank you very much, sir, to both of you, Dr. Ujjwal and Dr. Santosh once again, and Dr. Soumya Darshan Nayak for chairing this wonderful sessions, which has really been of enlightenment to all. And we in Astera, INTAS, always support such academic initiatives for the well-being of the medical fraternity and for the patients at large. Thank you very much, sir. Good night to all of you. Thank you, sir.
Thank you.
Thank you.
Thank you,
Bye-bye. Soumya, bye-bye.
Thank you, sir. Thank you.
Yeah.
Thank you very much, sir. Thank you. Good day. Thank you, sir.
Bye-bye.
Thank you, sir. Thank you so much.
Thank you so much.
Thank you, Chinmay.
Thank you, sir. Have a wonderful night. Good night, sir.
Good night.
Bye. See you.
You can make it, you can discontinue the live session. The support team can discontinue the live session. The support team can discontinue the live session.